Here's some notes on electrolyte management in cardiopulmonary bypass. Magnesium is most commonly used to promote conversion to sinus rhythm post-bypass, and it's often given prophylactically to prevent dysrhythmias. A typical dose of magnesium might be 2 to 4 grams. Hypomagnesemia is common post-bypass because you give magnesium-free fluids during bypass. You might also induce diuresis. In general, magnesium has a relatively low side effect profile if you give it, so it's usually safe to give prophylactically. Calcium is the next electrolyte. It's commonly given to promote ventricular contractility when weaning from bypass. Hypocalcemia is common after bypass because of blood transfusions. Blood and blood products contain citrate, which chelates calcium and can cause hypocalcemia. You can also have hypothermia-induced coagulopathy, which requires blood products, and that might be the reason you have so much chelating citrate in your blood. You should rapidly correct hypocalcemia when weaning from bypass to maintain cardiac contractility. Potassium is another electrolyte that needs to be managed. Hypokalemia can occur post-bypass. The main cause is aggressive insulin treatment for hyperglycemia, and of course when you give insulin, you cause an intracellular shift of potassium. While cardioplegia solutions contain high potassium, they don't necessarily affect your systemic levels. They do have a lot in the solutions, but you have so much body potassium that's intracellular that you might not affect your systemic levels when giving cardioplegia solutions. You might need to replete potassium to prevent increased automaticity and arrhythmias. Lastly, we have phosphorus. Phosphorus can be depleted post-bypass, especially with blood transfusions. Same as calcium, the citrate from the blood products can chelate the phosphorus in addition to the calcium. And hypophosphatemia is associated with prolonged ventilation time and greater post-op vasopressor requirements, as well as longer hospital stays.